Hello, everyone, and welcome back to your favorite channel in understanding cancer, Cancer Reach. Cancer Reach is an initiative by our very own onco expert, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers access the right treatment at the right time. Now, when you hear the word cancer treatment, your mind immediately jumps to conclusions about chemotherapy, radiation, or maybe the new age immunotherapies. But what doesn't get talked about much is what happens after these treatments are administered. So, what happens is there are a lot of reactions which happen in our body which is necessary to understand to get a full impact of the chemotherapy or the radiation or the new generation immunotherapies which are being introduced to the body. So, today we take up this opportunity and introduce you to a serious topic, but also it is surprisingly very much misunderstood in the medical community. That is nothing but the tumor lysis syndrome. Before we start, let me introduce our doctor to you. Dr. Krishnamani is a renowned medical oncologist with over 15 plus years of experience in the field of oncology. He completed his graduation in 2005, PG in 2010, and specialized in medical oncology in 2014. Throughout his career, he has been an integral part of various hospitals and organizations across India, earning recognition as one of the country's leading oncologists. He has been actively involved in academic contributions and professional development. He has also served as reviewer for many esteemed journals. Currently, he is working in AOI hospitals in Hyderabad. A very warm welcome to you, sir.
Hello and welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. And thank you for having me. And today we shall, as you said, discuss about this very important and burning topic called tumor lysis syndrome.
So, sir, when we begin, can you tell us what exactly is the tumor lysis syndrome?
So, tumor lysis. Tumor is cancer, lysis is breakdown. So, when a cancer cell breaks, that is called tumor lysis syndrome. So, the whole thing is based on this fundamental concept. So, a cancer cell, usually because of treatment, gets destroyed, and whatever is inside the cancer cell comes into the bloodstream, because of which there are certain effects on the human body. There are some electrolyte imbalances. That is called tumor lysis syndrome. Please note, it is an emergency. It is an oncologic emergency. So, it's a syndrome due to the breakdown of tumor cells, usually due to treatment. It is an oncologic emergency, has to be treated at the earliest. Otherwise, it can be very fatal. It can lead to death and suffering. And it is not a permanent kind of a problem. It is usually a temporary and initial problem in certain cancers. And once it is dealt with, your rest of your cancer treatment goes on after that.
So, do we have any specific causes for this particular syndrome?
So the causes are, it is usually seen in those cancers which have a very high proliferative rate or fast growth rate. So cells are growing fast, they die fast. When they die, they have to come out through your kidney. Your body kidney has to be able to survive that load of incoming dead tumor cells. So what are the causes? Somebody who has a tumor which has a very high doubling rate, like Burkitt's lymphoma, like acute lymphoblastic leukemia, that is blood cancer, like some types of other lymphomas called non-Hodgkin's lymphomas, some other. So any of these diseases which has a high doubling rate, diseases which have an extremely high WBC count, sometimes in some chronic leukemias. Chronic leukemias, what happens is the high WBC count increases over few months to years. So the body is adjusting to that. In acute leukemia, what happens? Acute means short period you have blood cancer. The WBC count goes up rapidly. So your body is unable to take that load. Your kidneys are not able to take the dead cells. So acute myeloid leukemia, acute lymphoid leukemia, Burkitt's lymphoma, Then non-Hodgkin's lymphoma, CML, CLL, rarely some solid tumors, bulky solid tumors. All of them can lead to tumor lysis syndrome. Diseases which have an extremely high WBC count could be a lymphoma or a leukemia also. Because more the WBCs, more the destruction of the cells, more the effect on the kidney. Patients who have a disease from a very long time and who are not taking treatment. Got it? So that means they have a large load of tumor cells. Fourth, when you in sensitive cancers like these lymphomas and leukemias, you hit them with chemotherapy, you hit them with steroids, they immediately die. So treatment itself is an important cause. That's why you should go slow. Poor hydration. If you don't hydrate these patients, that is, don't drink lots of water, you're not going to give them a lot of saline, they end up with tumor lysis syndrome. So the causes are tumors per se, which have a high growth fraction, high WBC count, treatment like steroids or chemotherapy, sometimes radiation, dehydration, patients who present for a very long time without seeking treatment, patients who are already having kidney problems, heart problems. These are all some of the important causes.
So, sir, as per my understanding, what you have said is that it is more of disease dependent rather than any specific drug dependent. Would that be correct to
Correct. Now
understand?
suppose Correct. Now suppose somebody comes with breast cancer. Disease has spread to lung, liver, bone. Stage 4. Now another person is there. Acute lymphoblastic leukemia, ALL. WBC count is 75,000 or 1 lakh. Now, both are having advanced disease, but the ALL guy is more in problem for tumor lysis because that 1 lakh WBC, once you give chemo, starts rapidly dying and floods the circulation and your kidney. Breast cancer patient is not going to develop it that commonly. So it is more of an inherent disease problem, and how quickly also you are reducing the disease. So sometimes in these kind of diseases, your treatment should be in a phased manner. Now, for example, in an NHL, non-Hodgkin's lymphoma, large lymph nodes are there. Imagine 10 centimeter lymph nodes in the abdomen, in the armpit, in the mediastinum, in the neck. We call them bulky disease. Any tumor in lymphoma, which is more than 7.5 centimeters, is called bulky disease. When you have bulky disease, that it is exquisitely sensitive to chemotherapy. That cells will die quickly and flood your circulation and kidney. So what are you going to do? Any lymphoma which is exquisitely chemosensitive with bulky disease, you will go slow. You will not immediately hit him or her with chemo, with full dose chemo. You will give something called pre-phase chemotherapy. Pre-phase chemotherapy is like a trailer of a movie. You will give a small dose of steroid, small dose of chemotherapy. You will tease the tumor. Okay, you will tease the tumor by giving the small dose so that the tumor slowly starts shrinking and doesn't flood your kidney immediately. Then after 1 week, what you will do, you will start your full chemotherapy. By that, your kidney is primed to the load of tumor, and already the tumor has shrunk a bit. Otherwise, what will happen? The minute you give chemo, from the next day, the cells start dying and it will flood your kidney and you will end up in tumor lysis syndrome. Then you are in unnecessarily problems. You have to deal another medical emergency apart from your treatment, which is apart from your cancer, which is a lymphoma.
Who would be at a more risk of developing this syndrome
All these
based
people
on
whom we
age?
discussed. High age, dehydrated, comorbidities like diabetes, hypertension, heart problem, kidney issues, somebody who has a tumor like an AML, ALL, Burkitt's, non-Hodgkin's lymphoma, somebody who presents with very high WBC count, somebody who is dehydrated, they are all at a super high risk. Or somebody who doesn't start with pre-phase, they directly start the full dose chemotherapy, and somebody who doesn't receive prophylaxis. Prophylaxis means what? You receive some treatment before itself, thinking that this fellow will develop problem. Now, when it is going to rain, what do you have in your bag? You have an umbrella. That is prophylaxis. The same way, if you see a bulky lymph node, if you see NHL with large lymph nodes, you're expecting tumor lysis. Before itself, you will start giving certain medicines called allopurinol. You will start hydrating the patient well, make him drink lots of water. You will alkalinize the urine sometimes. So these are all precautions so that he doesn't develop. So tumor lysis syndrome, it is better to prevent rather than treat. So what you should understand is treating treating anybody will do. You should identify who is the potential person who will develop TLS. Start using prophylactic treatment for that guy so that he or she doesn't go into TLS. That is your victory. So these are all the patients who are at high risk, the patient who don't receive prophylaxis. So what you should do, identify the patients at high risk, hydrate them well, give lots of water and saline, give prophylactic drugs like allopurinol, okay, for uric acid, avoid high potassium foods like banana, coconut water, avoid fruits and fruit juices for some time because it contains high amount of potassium, ensure that they're hydrated well, they are not constipated. So that we will anyway discuss during the diagnosis and treatment.
What would be some of the typical signs and symptoms that these patients experience with the syndrome?
So what we should understand is rather than go from signs and symptoms, let us understand the basic mechanism. When a tumor cell dies, inside whatever is there, it comes into the blood. What is there inside? First which is there is uric acid. It comes into the blood, so your blood uric acid goes up. Potassium is there. It comes into the blood, blood potassium goes up. Phosphorus is there. It comes into the blood, blood phosphorus goes up. Got it? This phosphorus in the blood takes away calcium. So calcium goes down. So in tumor lysis syndrome, potassium will go up, uric acid will go up, phosphorus goes up because the cell breaks and all this comes into blood. Only calcium will come down because calcium marries the phosphate, which is already elevated. This calcium and phosphate goes and blocks your kidney to form calcium phosphate stones. So you start developing creatinine problem, kidney problem. So your creatinine will go up. So now your symptoms are based on this. Symptoms are based on high uric acid, symptoms are based on high potassium, symptoms are based on low calcium, and symptoms are based on kidney problems. Now tell me, what are the problems you will have? If my uric acid goes up, I will have joint pains. I will be dehydrated. If calcium goes down, hypocalcemia, what will happen? Patient develops tetany, we say. That is, they develop cramps in the legs and hands. Okay, they develop cramps in their legs and hands if you develop hypocalcemia. And also, they can also develop some kind of heart issues. They can develop heart issues. Now, if potassium goes up, it's a very dangerous thing. Potassium is a very narrow range body, 1.5 to 5.5. If high potassium you have, it can go to your heart and stop your heart. So you can develop sudden cardiac death. You can develop heart arrhythmias, we say. That is, heart rate may go up or down. You can develop fits, seizures. You can go into coma. And finally, when your kidney is affected, your urine may stop, your creatinine will go up. Got it? You may develop swelling in your legs and your eyes. So these are all the symptoms. So the cell breaks, it releases uric acid, releases potassium, releases phosphorus. Phosphorus takes the calcium. That's why everything goes up except for calcium, which goes down. I may develop heart problems. I may develop arrhythmias. I may develop confusion, coma, and seizures in the brain. I may develop cramps in my body because of low calcium. And because of the kidney issues, I may develop swelling of the face, legs, and may stop passing urine. So these are my symptoms.
Okay, sir. Coming to the diagnosis part, how do you diagnose this condition?
Simple. Do your blood test. Now you tell me, potassium, what will happen? Go up or down?
It will increase.
Potassium increases. Uric acid, increase.
Increase.
Phosphorus, increase. Calcium,
Increase.
decrease. Creatinine,
Decrease.
increase. Done.
Increase.
Simple. So you
So
will just
only
do a
blood
blood
test.
test. So the
Okay.
typical patient is a leukemia or a lymphoma, high WBC count, very sick patient. You have started treatment or even without treatment also sometimes they can come with you. Potassium is high, uric acid is high, phosphorus is high, creatinine is high, calcium is low. That's all. That is your definition of tumor lysis syndrome.
Sir, how do you treat patients with this condition?
How do you treat? Very simple. Remove everything from the blood. Remove everything from the kidneys. Flush everything out. So adequate hydration. Give a lot of saline. Make the patient drink lots of water ideally. Saline is given at a very high rate, sometimes 200 ml per hour. Normal, we generally give 75 to 100. This time we have to double so that everything gets flushed out. Calcium is very low, so give calcium gluconate injections. Potassium is very high. So initially, we give nebulization with salbutamol. It pushes the potassium back into the cell, but that is temporary. You give insulin, that also pushes the potassium back into the cell. That is also temporary. Permanently, if you have to push potassium out of the body, you give a medicine called potassium K-exalate. It pushes the potassium out in the stool. So temporarily, because potassium is the most dangerous part here, potassium can stop your heart. So first you'll push it back into the cell. What has come out, right? You'll push it back with nebulization, with your salbutamol nebulization, and with your insulin dextrose. When you give that, potassium goes into the cell. And then it can again come back, right? So you'll remove all the potassium from the body through the stool with potassium K-exalate. You have to protect your heart. So you create a protection for your heart by giving calcium gluconate. It prevents heart rate fluctuation. Creatinine, you will give a lot of saline. Okay. Finally, uric acid. You will give a medicine called allopurinol. Now, this allopurinol, what it does is new uric acid is prevented from forming. But already formed uric acid is there, right? Allopurinol doesn't act on it. For that, you need a drug called rasburicase. It is like allopurinol prevents new dirt from coming, new uric acid from coming. But already formed dirt is there in your house, already formed uric acid in your blood. That also has to be removed. That work is done by rasburicase. It breaks down that uric acid. So in severe tumor lysis, you need rasburicase. Or in high risk tumor lysis, if they are going to develop, you give rasburicase before itself. So rasburicase helps remove already formed uric acid. Allopurinol helps in forming uric acid. Finally, if the patient is super sick, none of this is working. Again, the potassium is going up. Again, the uric acid is going up. Despite all this, then you have to do hemodialysis. That is, you will purify the blood and remove every damn thing from the blood. So the treatment is also the same. The investigations are also the same. The pathophysiology is the same. Uric acid increases, I will have two drugs, allopurinol and rasburicase. Calcium increases, calcium decreases, I will give calcium gluconate. Potassium increases, I will give calcium gluconate, K-bind or potassium K-exalate, and insulin dextrose. Creatinine increases, I will give lot of saline. If all this fails, hemodialysis. So
So
this is
before
my
we, is there a is there any algorithm which you follow to identify these kind of patients and prevent this syndrome from happening in such patients?
So tumor lysis, again, I'm telling you, is all about prevention. All the high risk features we thought. There is a scoring called Cairo Bishop scoring. This is for the medical graduates, not for laymen, but medical graduates. You divide those patients into low risk, intermediate risk, high risk patients. If somebody is having seizures, fits, in coma, creatinine is very high, the uric acid is very, very high, all based on those features, that person is high risk and certain tumors. So how do you prevent for a general public all these lymphomas, leukemias, high WBC count? Start thinking about tumor lysis. Start giving them good hydration. Avoid coconut water, banana, fruits, fruit juices to prevent potassium. Give lot of saline so that they flush the urine. Check uric acid, potassium, phosphate, calcium, creatinine. Start allopurinol immediately. If you think they have large bulky nodes, they will develop TLS. Already give. Am I audible?
Yes, sir. Now you're audible.
If you feel this patient is going to develop TLS, then start giving them rasburicase also. Before giving rasburicase, you should do a small test called G6. Before giving rasburicase, you should do a small test called G6PD test. Some people have this G6PD enzyme deficient in the blood. If they are given rasburicase, they will develop hemolysis. That is, their blood cells will break down, RBCs will break down. So always do G6PD testing. If you are not G6PD deficient, then you should be given rasburicase. So prevention is hydration, allopurinol, rasburicase in high-risk patients, do G6PD before testing, avoid potassium-rich feeds, test the electrolytes every day in these patients, start with pre-phase treatment, that is slow treatment, don't go intensively with chemo because you may give chemo, cells may die, but patient also may die. And monitor the electrolytes, monitor the urine output every day, monitor whether they're having breathing difficulties, seizures, coma, kidney issues, do all the tests every day, hydrate them well. And once the tumor load decreases, once for continuously for 3-4 days, if the electrolytes are normal, then you need not worry about tumor lysis. You have come out of that episode.
Okay, sir. So we have a few myths with us today. So the first one is that TLS is always caused by chemotherapy.
TLS can occur spontaneously if you have large bulky tumors. It can occur with steroids, chemo definitely, rarely with radiation also.
TLS only affects patients with hematological malignancies.
No, we discussed sometimes with breast cancers, lung cancers, germ cell tumors, you can develop TLS. If you have large volume disease, you are at risk for TLS.
Third one is TLS always results in kidney failure.
No, you can prevent TLS, which we spoke about, and you are doing everything to prevent kidney failure only.
TLS is easily preventable with only hydration.
No, you have to aggressively do hydration, give allopurinol. If you are worried based on the risk scoring, give rasburicase, do G6PD, avoid all the diets which we told you, and go slow with pre-phase treatment. That's the way you prevent.
Okay, sir. Sir, any parting message for the audience for today's topic?
So this is a completely medical topic. So laymen may think this is out of syllabus for them. But why we wanted to go into this is it's an emergency, but it is preventable. You should have an eye for these kind of cancers, identify, and as I said, take all those necessary preventable measures. It's a temporary thing. If you cross this battle, then usually it doesn't come back. You are worried about your cancer treatment. And it is the initial problem in usually hematological cancers like leukemias and lymphomas. It will require hospitalization. It requires regular blood checks and all that. But it is worth it so that we prevent it and then we don't end up on dialysis, or we prevent it and we don't end up succumbing to tumor lysis.
Thank you for this informative session, sir. I'm sure the audience would love your insights on this topic as well, even though it is not directly a core subject for the layman, but I'm sure they will all enjoy listening to this topic and they will definitely revert back with whatever queries they have in the comment section. Thank you everyone for joining. Thank you, sir.
Thank you so much.